In this video, we shall be discussing 5 key points to be kept in mind while performing therapeutic penetrating keratoplasty. We will be discussing these 5 points in the following heading: selecting trephine size, partial thickness trephination, excision of ledge, peripheral iridectomy and formation of angles. So this was a case of 54-year-old gentleman with a full thickness corneal infiltrate of fungal etiology with collagenolysis which was not responding to medical management. He was advised to undergo therapeutic penetrating keratoplasty. Flaring ring can be used. However, in therapeutic cases, it is usually not preferred as it is difficult to secure in chemos conjunctiva. So the first point to be considered is selecting trephine size. Trephine size is kept such that it is at least 1 mm beyond the infiltrate size in its largest dimension. Trephine, once selected, is placed on cornea to confirm that infiltrate is completely covered in the area of trephination. For partial thickness trephination, we first stabilize the globe with non-dominant hand. Trephination is done in primary position of the globe to have a straight host cut. Equal pressure has to be kept between thumb and index finger so that pressure gets equally distributed. Sharp end of 15 number blade is kept perpendicular to the cornea to deepen the groove up to 80% depth. Multiple entries are made into the anterior chamber with MVR blade to prevent sudden decompression. Viscoelastic is injected into the anterior chamber and host corneal tissue is excised, keeping the blade of scissors perpendicular to the groove. Complete excision of ledge is ensured, otherwise it may leave behind residual infection or become a source of recurrence. Rest of the host tissue is excised as described previously. Two PIs are made superiorly at 10 and 2 o'clock with Vanna scissors. Tip of the Vanna scissors is kept pointing outwards. First primary suture is taken at 12 o'clock at 80 to 90% depth. Second is taken in a similar manner at 6 o'clock such that tissue gets divided into 2 equal halves by this suture. Angles are formed with viscoelastic substance till all secondary sutures are taken, and thereafter angles are formed with BSS. Tip of the cannula is directed towards the angles to prevent detachment of the graft's descent membrane. Visco-BSS exchange is done at the end of the surgery to ensure complete removal of viscoelastic substance from the anterior chamber. Water tightness of the graft host junction is checked with the help of dry aerosol sponge. Knots were buried towards the graft site. So, to summarize 5 key points, trephine size should be at least 1 mm larger than the infiltrate size in its maximum dimension. Stabilize the globe while trephination. ledge should be completely excised. 1-hour scissors should be kept pointing outwards while making PI. And while angle formation, tip of the cannula is directed towards the angles. Thank you for your patient hearing.